Then the last thing I want to talk about, and it always seems I'm like, I was going to say I was going to end early, but it seems like I can't. So let's talk about, just one thing about acute kidney injury. Acute kidney injury is in general, described as a decrease in urine output, fluid retention, metabolic acidosis, hyperkalemia, hyperphosphatemia. Those are things that characterize, acute kidney injury. How do we define acute kidney injury? I like using KDIGO for your boards and in clinical, the kidney disease improving global outcomes. And I put some of the definitions of it, which include an increase in serum creatinine greater than 0.3 milligrams per DL within 48 hours, an increase in serum creatinine to greater than 1.5 times the baseline over 7 days, or a urine volume of less than 0.5 mLs per kilogram per hour for 6 hours. So these are some of the ways that KDIGO defines acute kidney injury. So acute kidney injury can be divided into three main things. Problems that are pre-renal, intrarenal, or post-renal. So of course, pre-renal, you'd always think about someone who's volume down. You would think about someone who has renal artery stenosis. You'd be thinking about someone who's on one way could be manipulating that afferent arteria but causing it to vasoconstrict, or people who have, heart failure and have decreased cardiac output. It's all going to be pre-renal. Post-renal is going to be obstructive urine flow. But of course, a favorite for the boards is intrarenal. And intrarenal can mean damage to one of three areas in the kidney: the tubules, the glomerulus, or the interstitium. So of course, when you think about tubules, everyone's going to mention acute tubular necrosis. When you think about the glomerulus, you can think about glomerulonephropathies, nephritic syndrome. But the one I feel goes under the radar, which is why it's going to be a great question for your board exams, is, the interstitium, hence acute interstitial nephritis. And that's what I want to talk about today. So, when we talk about AIN, acute interstitial nephritis, it's a renal condition involving rapid decline in renal function. It's around 10 to 20% of all acute kidney injuries, and what causes, acute interstitial nephritis? Well, it could be medications, and that's 2/3 of cases. So I guarantee that's going to be the question on your board exams. You could be having infections. It could be a systemic condition. Of course, part of it will always be idiopathic. You're just not going to find out. So I really want to focus on drugs, and the most common drugs that can do this are things like antibiotics. So think of beta-lactams, whether it's we talking about penicillins or cephalosporins or carbapenems, quinolones. So whether these patients will be on things like levaquin or things like ciprofloxacin. Definitely you would think about cephalosporins can do that, sulfonamides, rifampin. And of course, other drugs are very important when you talk about things like non-steroidals, COX-2 inhibitors, PPIs, And of course, when you say infections, which one? Well, kind of all of them, but of course I listed a couple here like E. coli, Campylobacter, Salmonella. Different viruses can do it, funguses, and even parasites can do it. And immune system and systemic disorders, you think about things like lupus and Sjogren's, and even sarcoid. And once again, sometimes you just don't know. So when we talk about the pathophysiology about this, it's very interesting focusing on drug-induced, that, the drug itself sometimes, doesn't induce the interstitial nephritis until it just kind of reacts with, cells in the tubule. And once there's an interaction with the cells in the tubule, then it forms, a complex that will rev up your immune system. And when we talk about acute interstitial nephritis, it is a kind of T-cell mediated immunity. It's a type 4 hypersensitive reaction that occurs. So clinical features of this: patients may be asymptomatic, they be non-oliguric or oliguric, they could have some nausea and vomiting, even some flank pain. And what are some of the findings? One of the key findings when I think about interstitial nephritis is sterile pyuria. Why? Because where is all the inflammation? It's going to be in that interstitial space, not in the tubule itself. But you can have white blood cell cast, you can have some proteinuria, it's using the subnephrotic range. You can have microscopic hematuria, and of course, some peripheral eosinophilia. So to make the diagnosis, what do? Well, of course, get a urine analysis, get some blood work. I'm not saying you need to do a kidney biopsy, but if it's indicated, it's going to change your management, you could consider that. Treatment is always going to be remove the offending agent first. Then there'll be a consideration of steroids, hasten recovery. And then, unfortunately, in some cases, some patients go on to need renal replacement therapy, and they may need dialysis. So, with this being said, I know we're kind of nearing the end. I just want to do one question right here to kind of wrap it in all together. So, we have a 39-year-old man is evaluated for a serum creatinine level of 2.6 milligrams per DL. His baseline serum creatinine 4 months ago was 0.9. He has no symptoms. 2 years ago, he started lisinopril and amlodipine for hypertension. 1 year ago, he started a PPI for GERD and naproxen for his knee osteoarthritis. 9 months ago, he began atorvastatin for hyperlipidemia. On exam, he's afebrile, blood pressure is 136/84. And the remainder of the exam is unremarkable. They get a UA that shows a specific gravity of 1.015, which is normal, pH of 5.5, which is normal. There's 1+ erythrocytes, 3+ leukocytes, 1+ leukocyte esterase, no nitrates, and greater than 100 leukocytes per high-powered field with leukocyte and granular Cas. Which of the following drugs should be discontinued in this patient? So this sounds exactly what we've been talking about. This is somebody who comes in with acute interstitial nephritis. And what are going to be the drug combo that we think about? Is it going to be the statin with a calcium channel blocker, amlodipine? Is it going to be the ACE inhibitor and amlodipine? Is it going to be lisinopril and the PPI, which is omeprazole? Is it going to be the naproxen and the atorvastatin? Or is it going to be the naproxen and the omeprazole? Which one seems to be the right answer here? So if you think about what we talked about for the different drugs out there, remember non-steroidal medications can definitely do it, and proton pumps inhibitors. And I know that we have this classic, kind of like, triad of fever, rash, and peripheral eosinophilia, but what a surprise, it only really occurs in about 10, maybe 30% of cases with AIN. So I put this here because, when we talk about medications that can do this, first off, yes, non-steroidals, including COX-2 inhibitors, can be associated with that. But I really want to jump down to the bottom point that proton pump inhibitors are thought to be a risk factor for development of CKD. And some of these proton pump inhibitors induce AIN, maybe 10 to 13 weeks after exposure. And I put a little article up here because, the thought process, PPIs are not as benign as we think. They do a great job. Sometimes you really need to be on them. There are immense inhibitors of the, potassium, hydrogen, potassium, ATPase pump, but they do have consequences, whether we talk about, infections like the higher risk of C. diff, whether we talk about the higher risk of ventilator-associated pneumonias in some cases, whether we talk about, some of the problems with calcium and absorbing calcium when you're on PPIs. And of course, now it's going to be talking about chronic kidney disease, specifically talking about how PPIs can develop AIN. So something to remember for your boards. And, I just want to say, what are my beyond the pearls for your boards this time? I want to just go through these. Renal recovery through drug-induced AIN is usually complete if the drug is stopped immediately after the onset of kidney injury, and it may take about weeks to several months. An irreversible interstitial fibrosis can develop after 2 weeks of continued exposure, which is why discontinuing the drug is so important. Kidney biopsy should be considered if no improvement in kidney function after around 5 to 7 days of discontinuing the medication or the drug that you think is causing it. And early glucocorticoid administration may limit damage associated with drug-induced AIN. And with that being said, everyone, I know I did it again. I know I went overboard, but I really hope you mastered the gallbladder, you mastered diabetic kidney disease, and of course, I had to throw something with AIN. And hopefully, I can't wait to see you in person one day. And good luck on your board exams.
Thank you, Dr. Raj. We do have one question in the chat, so I'll just go ahead. If you can't see it, I can go ahead and read it to you.
All right. You know what? I can see it, but I love hearing your voice. Why don't you just read it to me?
Are there known SSRIs or SSRIs? I don't know what that means.
Or heme-onc drugs, or conditions that we should be aware of as AIN precipitates. And so, SNRIs. So yeah, the answer is that, there are always a lot of case reports and case series. I wouldn't say there's one that's kind of a blanket one you should know about. When you talk about AIN, it's hard to know what drugs will induce it. It's been around, AIN's been around for a while, and so there have been, associations. We definitely know certain antibiotics are just associated with this. But like what I mentioned, what causes it is when a drug goes through, gets filtered, interacts with the tubules, and when it forms that complex, it revs up your immune system. You get that type 4 hypersensitivity type reaction. So you never know what could do it, and you need to have a very low threshold to think about this. So definitely, when you say hem-onc drugs, oh my God, these chemotherapy drugs always do a number on my patients. So the answer is there are some ones that we know for sure based upon our history of giving these medications, but you never know. And that's why it's so hard to make this diagnosis, and you just have to have a very high suspicion. But great question over there. And once again, Roger, thank you so much thank you very much. You're the best. Elena, thank you so much. Everyone who always says these really nice things, you always make my day. It takes a while to make these presentations and really focus it then. I only get 90 minutes. So thank you so much. I appreciate it.